Hello, Arnaldo. I'm Thomas. Nice to meet you.
Hi, Thomas.
Actually, we are thrilled to have you here and to have the opportunity to interview you. I think it would be great to get to know you better. So could you please share more about yourself and your family?
Myself, well, it's very easy because my family is a very small family because my father and my mother, they passed away many years ago. My father was a dentist. And the reason why I am a dentist is because I wanted to be a dentist since I was a little child. And then I finished my high school and then I started my university. And then I graduated in medicine first, because at my time, there was no dental school. And to be a dentist, I had to be a physician. So I am a physician specialized in dentistry. At the end of the specialty, so-called, I realized that I was specialized in general dentistry without knowing anything special, really. And so because I fell in love with the endo, I decided to know more about endodontics. And then I tell you the little story. When I was just graduated in medicine and during the specialty in dentistry, I was doing some practice in the university, and I was surrounded by people who were extracting teeth one after the other, the little granuloma, the little lesion, extraction after extraction. And then I asked myself, how can it be possible to save these teeth and maintain these teeth in the mouth of the patient? And so I started to read articles and textbook, and it happened to me to read a chapter of, actually 2 chapters of Dental Clinic of North America. 2 chapters written by Professor Herb Schilder of Boston University. And when I saw the x-rays with the anatomy respected, the curvature of the roots, lateral canals filled with gutta-percha, I thought he was a magician. I said, wow, because I was so naive that I thought he was able to put instrument and gutta-percha point also in lateral canals. And honestly, when I found out that the lateral canals are cleaned by the irrigants, I don't need to put instrument, and are obturated by the gutta-percha, I don't have to put my specific cone, I was kind of disappointed. I mean, then it is so easy. While all the people were criticizing that Schilder's technique is too difficult, too time-consuming, is exactly the opposite. It's very easy, very predictable. And what I learned many years ago, because I spent a lot of time in Boston from 1978 to 1980, okay? And what I learned at that time, believe me, of course, new instrument, new material, new technology, new everything. But the principle, the basic principle, are still valid today. And I am practicing with those principles. And when I see my patient at the recall evaluation with a lesion perfectly healed, I'm happy. And so coming back from Boston, I decided to limit my practice to endo. After working as a general dentist for 4 years, doing also restorative, prosthetics, and everything. But especially during my work on about prosthesis, I came to the conclusion that I wanted to be responsible of something not made by somebody else, the dental technician, who can be a wonderful person, making a beautiful job and a beautiful crown and bridges. But I want to be responsible of doing something myself. And so I said, I want my gutta-percha inside the root canal, and nobody's allowed to touch it, okay? And so I decided to move my office from the place where I was since that time, at that time, and I moved where I'm still today with the practice limited to only endo. Only endo means non-surgical through the access cavity and surgical with the surgical approach, but still endodontic therapy. And I'm very happy. I'm very excited. I'm still enjoying what I'm doing every day.
Well, that's actually amazing accomplishment. I believe not a lot of people can share the same happy story as you can. That you've been practicing endodontics. So if I understand it correctly, so more than 40 years, right?
Yes, because I started at the end of the 70s. And so let's say beginning of the 80s, but so it's already 43 years, but actually they are almost 45.
Well, that's impressive. That's impressive.
So I think I have a pretty good experience.
Well, yes. Well, actually, that sounds inspirational. So yeah, thank you for sharing that. Actually, my second question was that you already answered 2 minutes ago. That a lot of kids when are dreaming to becoming a policeman, a fireman, a lawyer, etc., etc. And I wanted to ask you, did you dream of becoming a dentist? And actually, you said yes, even before my question.
Well, to be honest with you, when I was still in the high school, a pilot of the Alitalia airline came to visit the school and was advertising the work of being a pilot. So I went back home that day and I said to my dad, "Dad, I changed my mind. I want to be a pilot." And then he said, "Are you crazy?" And then I changed my mind. I'm happy.
So
However,
yes,
I'm still enjoying when I can fly. Actually, next week on Tuesday, I will fly to Riyadh. 1 week ago, I was in Bucharest. Beginning of September, I was in Helsinki. End of September, I was in India. So I like to travel and I like to fly. Every time I find some little airplane, very little one, I need to try, and I like to be in the air.
So maybe that could be your, maybe a hobby to have a pilot's license and fly small airplanes.
It could be, yes. It's my dream, not my hobby. I mean, today I think I'm too old to get the license, but it's okay.
Well, thank you for sharing your story. Well, now let's move on to the questions. Okay.
Yes.
Okay, wonderful. So, why did you choose endodontics over surgery in the field of dentistry? I feel that you already touched a bit of this topic, but maybe you can explore a bit more.
Well, I already partially answered also to this question. I choose endodontics because I couldn't believe that the teeth with the lesion, with the radiolucency, with the granuloma could not be treated. And so I started to check and study and looking for a textbook. And then I fell in love with endo, especially when I started to go to Boston University to know personally Professor Schilder, who has been always like a father for me, not just a teacher, like a father, like a friend. Just to tell you the good relationship that we had together, very, very unusual when I was a student. When I was a student at Boston University one day, and I was sharing the room where I was treating patients together with another student. Well, one day he asked me, "What did you do last night?" And then I said, "Well, last night I had dinner. I was invited at home by Professor Schilder, and also there was also Professor Dudley Glick from Los Angeles, another university." And he couldn't believe my word. "What? You have been invited at home by Professor Schilder?" I said, "Yes. What's so funny? What's so strange?" Very, very unusual. But he had a special relationship with me. I also invited him in Italy several times. But let me tell you another thing. Because Herb Schilder didn't publish so much. Few chapters in a couple of textbooks, few articles together with other students, other big names. But his students, through the years, made so many studies and theses and research that he could have published enormously, but he was maybe lazy, I don't know, or very jealous of his work. So one day, I decided to translate into Italian a little textbook, maybe 300 pages, maybe less, written by big names from the United States, Alfred Frank, Dudley Glick, James Simon, and Harvard Buras. And principle of endodontics in general. And they were covering a little bit of everything. And believe me, while I was translating the textbook into Italian, inside of me, I was thinking, wow, I could explain these things a little bit better, if not a lot better. And so after translating and having the book published by an Italian editor, I decided, this was 1987, I decided to write my textbook myself. And so a few chapters through the years, finally in 1993, the first edition of my textbook was published. But at that time, I still didn't say anything to Professor Schilder, who I knew he was very jealous. So one day he was visiting Florence for another reason, maybe giving a course or something. And I remember we were in the lobby of the Excelsior Hotel, in his hotel here in Florence. And then I said, Professor Schilder, I need to confess one thing, and I hope you will be happy. I decided to write a textbook on your technique, your philosophy, or everything I learned from you. All the textbooks is dedicated to you. As a matter of fact, the title was Endodontics with the E and the S, beginning and the end, with the capital letters, meaning that from the very beginning to the very end of the textbook, I was the only author and I was following one single philosophy. And I expected he to be upset with me or jealous. Why you didn't ask me the permission? And blah. He started to say so many nice things about me and the project and the textbook that I wish I had the recording of everything he said to me. He was so kind. I told you, like a brother, like a father, like a friend, and not like just a mentor. And he was very proud. So he wrote the foreword for the textbook, which is unbelievable. And for the nice thing he said about me, about the Italian endodontics. So, and this has been the first edition, which was being published in 1993. And then maybe 10 or 12 years later, I realized that I had to add new chapters, new technology, new things. And so I came with a second edition, only in English, in 3 volumes, from 2004, 2006, more or less. And then also a few years ago, I realized that I needed new chapters. Like in the previous edition, there was no CBCT. How can I write a textbook without mentioning the CBCT? And many more things, new material, the MTA, bioceramic, and so on. And so about 2 years ago now, the Italian edition of the new edition, 1,600 pages, a lot, very heavy. And right now available in Italian and English. But as I already told you, within the end of this year, it will be also available in Russian.
Okay, so very nice to hear that. Yeah. Well, can we look at the dentistry a little bit, maybe from a different side, maybe from more from material side? Can we look at the dentistry more from material side? Could you please share your opinion on whether dentists have a decent salary in your country? But before answering, please mind that when we did our research, we know that you traveled 6 continents, visited more than 50 countries. So probably you already might know.
I visited for at least 167 countries, at least once. So
that's amazing. So could you please share, your opinion on this field?
absolutely. Well, just to use a Shields expression, endodontics is, as a treatment, is extensive and must be expensive also, okay? So, and I don't see any reason why 1 hour of time at the dental chair of the periodontist or the prosthodontist or the implantologist could be much more expensive than the hour of the endodontist, because we studied exactly the same. We came from the same university. We have the same responsibility. So, of course, it's not the same, because the implantologist makes much more money. By the time I try to negotiate the calcified canal, the other guy, he put 3 or 4 implants. So there's no comparison. However, unfortunately, in the average in Italy, the price of the endo treatment is not so high. And also because the quality is not so high. Don't forget that in Italy, we still, unfortunately, this is a shame, but in Italy, we still don't have postgraduate programs in endo, no specialty. We are all general dentists. The only specialty is orthodontics and oral surgery. That's all, okay? So if I go to the United States and get the specialty in perio, I cannot put out of the door of my office a plate saying specialist in perio, specialist in endo, because the specialty is not recognized. And this is the reason why in many dental offices, the owner of the office maybe has been in practice for many years, and he makes money with the prosto, today with the implants, and he doesn't like endo, so he hire someone who just graduated at the university, with very no knowledge. We have many universities in Italy, but maybe only in 5 or 6 or maybe not even 10 university. The students, when they are graduated, they know exactly what to do. In many other places, unfortunately, they don't know so much, okay? University of Turin with my friend Elio Berutti is excellent. Is one of the best equipped in Europe, I think. Milano with Cantatore, Rome, Naples, but these are good universities. But in other, not so good. And so in the office where the owner of the office makes money with prosto, endo is given to the young guy, then the price of that endo is also pretty low. But if you come to attend some lecture at the Italian Endodontic Society, we had the annual meeting only a few weeks ago, you can see the quality of the members of the Italian Endodontic Society. The quality is extremely high, and the price also are higher than the average. But this is correct because we made a lot of investment. I have endodontic, digital radiology. I have the CBCT. I have the microscope. My colleague, I have an associate in my office who does everything that I don't do, like prosthesis, crown, and put some implant. We take digital impressions. So all this equipment is pretty expensive. So of course, the treatment also must be expensive. Just to give an idea, I had maybe 1 year or 2 years ago, I had a patient coming from Monte Carlo, France, okay? And she was used to come to my office and to see my microscope, my CBCT, and so on. She had an emergency in Monte Carlo, and she went to a dentist. She entered the office. She didn't see anything of my equipment. She turned around and she left because she said, wow, how can he practice without microscope and everything? I installed the microscope exactly September 1995, so many years ago. And I couldn't imagine working without the microscope. And then later, of course, the digital radiology, the CBCT. I don't take a CBCT for every single patient, but every time I have a doubt, then I take a CBCT before a surgery, before a difficult treatment. I get information that I cannot see at the B-dimensional radiograph. So I take the 3D. And then many times I change my treatment plan, thanks to the CBCT, just to give you an idea. Of course, everything must be paid by the patient. And so the endo treatment must be expensive.
So yeah,
never like implant, but still.
Well, it's logical. So for the expensive, procedure that the doctor have to do, so we have to pay in an adequate price for that.
Exactly.
Well, Arnaldo, can you provide insights into extracting gutta-percha from apex? Perhaps you have your own specialized practices.
Let me ask you a question. What do you mean exactly extracting gutta-percha from the apex? From the inside the root canal in the apical portion or
exactly,
from...
Exactly.
Okay. Well, this is what we do. The last time I did something similar was about 2 hours ago on a patient where I had to do a retreatment and remove gutta-percha from the entire root canal because the previous obturation was not very precise and was a little short. So to remove the gutta-percha, the best thing to do is to use, today we have rotary instrument in night eye in a martensitic alloy. So they are bendable and very, very flexible and very resistant. So without any solvents, just by friction of the instrument rotating inside the gutta-percha point, inside the canal, I develop heat so that the instrument can enter inside the gutta-percha, and then having the blades towards the coronal aspect, all the piece of gutta-percha can be pulled out of the canal very, very easily. On the other hand, this rotary instrument is not allowed. I'm talking about a retreatment, so I have no idea what the previous dentist did inside the canal, how large, working length, the taper, and everything. So that rotary instrument is not allowed to touch the dentin. Just touch the gutta-percha to remove it, okay? If it's not enough and I should go deeper, but it's dangerous, then I use some kind of solvent to dissolve the material with the solvent itself. And then with a little instrument, I penetrate into the solvent gutta-percha. And when I think that I remove everything and the instrument comes out clean without any pink material around, then I put again the solvent inside the canal, and then I use paper points. And then the paper points by capillarity will attract the solvent and the gutta-percha. When the last paper point comes out of the canal, nice and clean, without any pink material around, then I think that I remove maybe 95 or 99% of the gutta-percha. Now I put my irrigating solution, sodium perchlorate. I connect my apex locator, and now I can check my working length, and then I can start my treatment. Not before, because gutta-percha is an isolating material. And if the instrument is touching is rubber, okay? If my material is touching the rubber and not the dentin, the apex locator is not giving any answer. So I will start checking the working length only after I remove everything. And this is how I remove it when I do the retreatment.
Well, that's a very detailed answer. Well, thank you for that. How do you control the packing density of MTA in the apical third? Could you share a couple of tips?
Absolutely, that's very easy, because Well, first of all, in the apical third, I'm talking about cases where, like, I have a tooth that had a trauma when the patient was very young, or when he's very young. So I have an open apex where I cannot condense gutta-percha because I don't have the physiological taper of the canal, but the canal becomes larger in the apex, or maybe because of resorption, and the foramen at the apex at the apex is pretty large, so it's very difficult to condense the gutta-percha in such a large foramen because of the resorption, or it's impossible to condense when the foramen becomes bigger because the tooth is still immature. In this case, I use the so-called apical barrier technique, which means I position 3 or 4 millimeters of MTA at the foramen, at the apex. Of course, much better and much more precisely using the microscope. And then I have a carrier to position very gently the MTA in the apical part of the canal. And then I position with a sort of a syringe, which is can be a so-called Dogan carrier, from the name of Joseph Dogan, who invented this special syringe, where you take like a little piston of 2 or 3 millimeters of MTA each time, and I position under the microscope exactly next to the foramen. Then, initially with very delicate with paper points, and then with a shieldless plugger, metal plugger, I condense the material inside the canal. To improve the compaction and to remove the air bubbles, when I have the metal plugger in contact with MTA, then I ask my dental assistant to touch my metal plugger with an ultrasonic tip. So I transmit indirectly ultrasonic vibrations to the MTA, which improve the compaction, remove the air bubbles, and so the material is very well compacted. And this is can be done not only in a non-surgical therapy for an open apex, but also when I do surgery to condense as much as possible my MTA during surgery as a retrofilling material.
Okay, well, thank you, Arnaldo. And when do you find it effective to use reciprocating instrument?
Thank you for asking me this question.
Yes.
But let me tell you that reciprocating instrument, I don't like them for the simple reason that when you use the reciprocating means that the instrument is rotating by itself with the endomotor about 150 degrees clockwise and then 50 degrees counterclockwise, okay? Which is the motorization of a movement that James Rowan invented and described in the Journal of Endodontics many years ago, which is called the balance force technique. So you rotate in one direction and then counter-rotate in the other direction. Well, when you rotate in one direction, the instrument tends to penetrate inside the canal, taking debris in a coronal direction. When you do the rotation in the opposite direction, counterclockwise, the instrument tends to come out of the canal and push debris apically. So the beauty of the endodontic literature is that you can find whatever you like. Do you like articles saying that the reciprocating movement is very safe and doesn't push any debris outside the foramen? You can find it. But I can also find articles saying exactly the opposite, that when you rotate counterclockwise, you push material, and actually there's more risk of extrusion of debris. Extrusion of debris means also postoperative pain, okay? More risk of extrusion with the reciprocating movement. But also, I was born as an endodontist using my hands and now rotating instrument working in the way out, not pushing in. And then when you use reciprocating, you need to push in an apical direction so that the instrument will engage the dentin and cut the dentin to make progress in the working length, to the working length. I was born with an opposite philosophy. The instrument is rotating in a way out, not pushing in. Okay, again, to avoid any risk of extrusion and risk of postoperative pain. One thing that I hate to have in my office, and I try not to have it, is the emergency in a patient that I'm treating now. Like, for instance, I treat the patient today, and then tomorrow he comes, or maybe the day he is supposed to come for the final obturation, and I cannot make the final obturation because the tooth is still so sensitive, and then you start opening and closing and medication after medication. It's a waste of time. I try as much as possible, for sure in vital cases, to use a single visit endodontist. I open, clean, shape, and obturate. If you go to the hospital for the removal of your appendix, which is inflamed, it's not that the surgeon he cut the appendix today and the suture is the day after tomorrow. No, he will finish the surgery. Okay, in the vital cases, it's exactly the same. Sometimes in the retreatment or a big lesion, just to be prudent and for safety for the patient, I do a 2-visit procedure. So I clean and shape today, and then I close maybe tomorrow or in a couple of days or 1 week. Well, in the meantime, I want the patient to be comfortable, not having any pain or any emergency coming back to the office because he's still in pain. And this is the reason why I work with instrument cutting the dentin in the way out, never pushing in, never. This is what I learned from Herr Schilder 43 years ago.
So as I can see, you are very thoughtful towards the patient and very efficient and professional towards your profession. So that's very nice to hear. Is it mandatory to replace old fillings and perform a buildup before re-endodontics?
Well, it depends. And let me be more precise. In case I have a tooth has been treated many years ago, the restoration is still in a good condition. There is no leakage, no secondary decay, no radiolucency at the apex. Even though the root canal therapy is not exactly the best to be used in a big congress to show, look how good I am, okay? Even though the root canal therapy is not of the highest quality, but the patient is comfortable. There is no radiolucency. The restoration is still intact, okay? There is no need to remove everything. Let's assume that the patient needs a new restoration for aesthetic reasons, okay? There is no need to do a retreatment of the root canal therapy. If the removal of the old restoration and the new build-up and everything is made under the rubber dam. Because if it's not made under the rubber dam, then during the removal of the old restoration, and then before you isolate with the rubber dam for the new build-up, you can have contamination with saliva. So it's absolutely important that every single step is made under the rubber dam. If you have any doubt about contamination during your work, even though there is no symptoms, no radiolucency, no nothing, it's better to, or let's assume that the restoration has been leaking saliva and bacteria, even though I don't have any radiolucency and any symptom, then I suggest the retreatment, because it's terrible to make a build-up, to make a new crown, and 1 week later, the patient comes back to you with a big swelling, you had to remove everything. No, no, no. Okay.
Yes, then you put a sign that's on vacation.
Yes.
Do you see patients only in one dentistry clinic, your dentistry clinic, or in various different locations?
No. I see my patient in my office. For the simple reason that all the equipment that I have in my office in other places is not there. Let me give you an example. I am in a very, very good relationship with a very good friend of mine, whose name is Gianno Ricci. He's a periodontist who was at Boston University a few years before me, and he has a limited practice to perio. Years ago, when I didn't have the microscope, okay, and the patient had problems with the perio and endo needed treatment, then I used to go to his office with my assistant, my instrument, my stuff. He did the perio and I did the surgical endo, and then he sutured, and then I left. But since the day I have the microscope, if I have a patient having problems, and it happened several times, also recently, perio and endo problems at the same time, he comes to my office. I don't go to him because he doesn't have the microscope. And then he makes the incision, he takes care of the perio problem, then he leaves the chair, I sit down, I make my retro seal at the apex of the teeth, and then I leave the chair, and he goes back for finishing, suturing, and everything. So we do together, but in my office. I don't go in other places.
Okay, thank you. And what is your method for disinfecting gutta-percha pins?
Very, very easy and very fast. The disinfection, of course, cannot be done in autoclave because you melt everything. This is a joke. But just 60 seconds in the sodium hypochlorite is enough to kill bacteria, viruses, spore, and everything. So before using my gutta-percha point inside the root canal, I leave them in a bath of sodium hypochlorite. Sodium hypochlorite I started years ago with 2.5%. Then I went to 3%, then 5%. And then today I use it at 6%. The percentage, increasing the percentage, you increase the power of digesting the protein, bacteria protein, pulp tissue, and everything. Two things to accelerate the digestion by sodium hypochlorite. 6% is the percentage that I use, and then not to sterilize the gutta-percha point, but to irrigate the root canal. I prefer to have the irrigating solution not at room temperature because it's too cold, but at least 40 or 45 degrees centigrade. I know that immediately after I introduce my irrigating solution in the canal, the temperature will drop down to 37, which is the temperature of the body of the patient. But one thing is to have a warm solvent, a warm disinfectant, the sodium hypochlorite, which goes down to 37, compared to a cold irrigating solution, which will take time to arrive to 37 degrees. And we know that we use sodium hypochlorite because the sodium hypochlorite has the only irrigant having the capability of dissolving the proteins of bacteria, proteins of the tissue, and the dissolution of proteins is a chemical reaction. Like any other chemical reaction, is accelerated by heat. That's why I don't use, especially in wintertime, I don't use sodium hypochlorite at room temperature. Room temperature is fine to digest, to disinfect the gutta-percha point. But inside the root canal, I prefer to preheat just a little, not too much, but few degrees above the body temperature. That's it. Very easy.
Piccola.
Piccolo. Yes.
Well, if an instrument is removed from the root canal and the fragment ends up behind the apex, does it necessitate tooth extraction, in your opinion?
No extraction. Listen, the only indication for extraction is when you have a vertical fracture of the root. Now, of course, the tooth has to be extracted. But you are asking me if I remove if I remove an instrument from the root canal, and I notice that the instrument is a little bit shorter because a part of the instrument remain inside the root canal. Of course, no extraction. We have several options, okay? And the easy option is trying to bypass the little fragment. Now, it depends how big, how engaged is the fragment, where is the fragment in the coronal portion, in the middle, or in the apical portion, or through the foramen. Okay, it's different situation. But first of all, I tell the patient that, well, let me tell you that honestly, in the, doing endo, and if we are honest, we must admit that we, and I say we, including myself, break instrument inside the root canal, okay? Years ago, more often. Today, I'm honest with you, since the very first day when I started to use the instrument, rotating instrument that I still use today, and then I will tell you which one, or if you don't want me to make a commercial name, I will not make any commercial name, but I will tell you the principle of this instrument, okay? Since that day, which was January 2012, I didn't have one single breakage. And before that, I broke everything. But of course, in town, I am the one who's supposed to remove broken instrument broken by somebody else. I'm not allowed to break instrument myself. So if it happened to me, the breaking instrument, of course, I did my best to remove it, or at least to bypass it. What it means bypass it? If the patient has to understand that the problem is not the little piece of or metal inside the root canal. The problem is that the little fragment will block the disinfecting irrigating solution and the obturating material at the gutta-percha. And so it will be impossible to remove bacteria apical to the fragment and to seal that portion of the canal. On the other hand, if I can bypass the fragment and then I bring irrigants and then gutta-percha to seal the entire root canal space, the patient can survive for 150 years, having my gutta-percha inside the root canal for the entire length, and in some point, a little fragment of metal. And the patient has to understand this, okay? But let's see the other situation, because I have a situation like this that I show when I give courses about surgery, that a broken instrument was sent to my attention, where the instrument was broken half inside the canal and half outside in the foramen, was sticking out in the periapical tissue. And so I said, well, this will be impossible, extremely difficult to remove it from the coronal aspect. So I decided to do surgery. And it was a good idea, because during the surgery, when I removed the little piece of metal, was a rotary instrument. And let me make a comment. Since the day when the rotary file became more popular, we can see many, many more broken instruments compared to the hand stainless steel instrument before. Because many people, they start push the instrument inside the canal. The instrument is blocked because the canal has not been pre-enlarged. So the tip is blocked, it doesn't turn, the motor keeps turning, and like the American says, the instrument separates, like was his decision to separate. No, the instrument has been broken, not just separated by the dentist, okay? So in that case where I did the surgery, the instrument was broken beyond the apex. And then during the surgery, I removed 2 or 3 millimeters of the root apex. I removed the broken instrument, and then I noticed that the apical part of the root had a vertical fracture. That means that the instrument was engaged so well into the dentin at the foramen that will act as a wedge and broke and fracture the root apex in the apical portion. Thank God, after removing 3 millimeters of the root apex in 2 pieces because it was already fractured, and then I shaved and removed more dentin until I saw the fracture disappearing, then the prognosis remained excellent. And I have the recall evaluation with the excellent healing. And so it was a good decision to do the surgery in a case like this. But usually no extraction for sure. The ideal is to remove the broken instrument. But sometimes it's enough to bypass it. Especially, and this is one more reason why I take SBCT, because the roots were more often, they call it break instrument, are the mesial root of lower molar and mesiobaccal root of the upper molar. These roots have 2 canals. The 2 canals can be independent or can join together. Especially if they join together, one canal goes straight and the other one makes an extra curvature when it's joining with the other one. And because of the extra curvature, this is the reason why many times the instrument breaks. Now, let's assume that I can negotiate the canal of the same root where there is no broken instrument. And then I can bypass, without removing it, I can just bypass the fragment in the other canal. Then I explain the patient that I don't need to remove the fragment, and because to remove the fragment, I have to make space around it. And I have to remove dentin with the risk of making a perforation, which is worse than having a broken instrument. And so if I explain, look, the apical portion is in common with the 2 canals. I arrive to the foramen coming from one direction. I don't need to remove the fragment from the other canal because the part in common has been already cleaned coming from the other direction. So I show the patient the X-ray. They prove that the 2 canals are joining together, and then the fragment is still there and he is happy, no pain, no nothing, because the only portal of exit of the foramen, of the canal, the foramen, has been sealed coming from the other canal. So if the 2 canals are joining together, it's good news. The instrument can remain in one of the 2 canals once I am in the apical portion coming from the other. Different, but funny situation.
Well, that's approach talking with many years of experience, I suppose.
Yes.
So, Arnaldo, which way, in your opinion, is better, more effective, safer for condensation of gutta-percha, lateral or vertical?
Thank you for asking me this question, but you asked the question to someone who is not 100, 1000% convinced that vertical is much better than lateral. Let me give you an example. If you ask a question to someone who is not a dentist, okay, and you ask, look, I have a cavity which has a taper, okay, and has one opening at the end, but maybe has also opening on the side. It's more logical to put cold pieces of rubber and condense laterally in this cavity, or is more logical to put one single piece of rubber that not only will seal the opening at the end of the cavity, but because I soften the material, rubber, the gutta-percha point, with the heat, and then I condense vertically, follow a very simple law of physics. Hydrodynamic physics is the law of Pascal, okay? The vertical push will be composed in a lateral direction. And so if there is a lateral opening, it will be filled automatically by itself without any effort on my side. So I repeat what I said before. The lateral opening, the lateral canals, which are responsible of lateral lesion, bacteria, toxins, can go through the lateral canal to the periodontal tissue and develop a lateral lesion. Okay, lateral lesion is a lesion of endodontic origin exactly like the one at the apex. There's no difference. One is at the apex, the other one is lateral. And every opening between the inside of the root canal and the external periodontal ligament and the periodontal tissue has to be sealed, because I have cases where the canal, the main canal is obturated, but there is a lateral lesion, okay? Then I do a retreatment. I have cases with a non-surgical retreatment and I fill the lateral canal and the lesion disappears. Or I have other cases where I did the surgery and they retrofill only to the lateral canal. And after filling the lateral canal, the lesion disappeared. Okay, so the cold lateral condensation is not logical for this reason. And so this is a very, very controversial topic, because it's much easier to put one cone next to the other, as many as you want, depending on how much time you have. On Friday afternoon, the lateral condensation is faster, but because you have to leave for the weekend. But it depends how much time, how much effort you put. But let me tell you another story, because if you want to perform lateral condensation very well, you have to condense laterally as many gutta-percha points as possible. The first one goes basically to the working length, okay? The first lateral condensate should arrive 2 millimeters from the first one. Now, in a curved canal, like the mesiopalatal, the MB2 of the upper molar, do you think it's possible to condense the second gutta-percha point 2 millimeters from the working length of the other one? It's impossible. So what is called lateral condensation is actually lateral condensation in the coronal and middle third, but not in the apical third. In the apical third is one single cold gutta-percha point. So I don't like it. And if you want to condense more with the specific instrument, which is a spreader, you need to put the spreader between the first gutta-percha point and the dentin to make room for the accessory cone. And all the stress is distributed not only to the main gutta-percha point, but also to the surrounding dentin. In other words, to perform correctly the lateral condensation, there is described in the literature, and it's not my idea, but the high risk of vertical fracture, because you push with a sharp metal rigid instrument between the gutta-percha and the dentin. You may fracture the dentin. On the other hand, in a warm vertical compaction, okay, performed correctly, the metal instrument and the heat carrier and everything, they never ever touch the dentin. I soften the gutta-percha point, I compact with the plugger the gutta-percha point, the heat carrier, my plugger, they never ever touch the dentin. So it's impossible to fracture the root with a warm vertical compaction. It's quite easy to fracture the root with a very well-performed lateral condensation. But let me tell you something that made me very, very happy. Years ago, you should know that another father of the American father of modern endodontics, his name is John Ingle. John Ingle died recently, was almost 90 or maybe more. And during his life, he wrote 6 editions of his textbook. When he was almost dying, actually, the edition was published after he died, but was only a few years ago. For the 7th edition, I was asked to write the chapter on obturation. I said, wow. John Ingle, lateral condensation man, herb shielder vertical compaction, okay? And they know I come from Boston University. So I said, wow, they asked me, vertical compaction man, to write the chapter on obturation. So I described the lateral condensation. I tried to be very kind. I didn't insist too much. And the lateral condensation is not logical, can fracture. I also make a drawing, okay? In my drawing, I asked the graphic designer to design some pink material even inside the lateral canal, which is impossible because it's a cold technique. It will never be softened enough to enter the lateral canal. But just to be kind, if you open the chapter in the 7th edition of the John Ingle textbook, the chapter that I wrote, I described the technique, and the first accessory cone should arrive 2 millimeters, which is impossible. However, it was a big, big honor for me to be invited, knowing that I come from Boston University, to be invited to write the chapter on obturation. I said, wow, John Ingle, big enemy of herb shielder, but they asked me to write the chapter. Okay, very welcome.
Well, that was very kind and very polite of you. But what I understand listening to your answer to this question, that the lateral or vertical, it would be impossible to debate with you and change your mind, probably.
Absolutely. Exactly. Well, I had this very strong discussion also recently with one guy who think exactly the opposite of me. And I remember that I was moderator when he was giving a presentation at the IFI meeting. IFI is the International Federation of Endodontic Associations, okay? And one of the very first meeting was in Rome, 1995. And I was moderator when this guy, I was giving his presentation, saying things that I disagree with 100%. At the end of the debate, I arrived to the conclusion. I said, listen, maybe I will not convince you, but for sure you will never convince me. So keep your ideas. I will keep mine. This is a guy who likes to stay short. He does exactly the opposite. He likes to stay short, losing lateral condensation. And then I finish saying, keep staying short in your obturation. And I say thank you because you keep me busy. Because one day I will retreat your failures.
Amazing. Argument.
But of course, but I'm happy that you understood that. I'm very, very convinced of what I said. But,
well, I can see how passionate you are answering this question.
But the simple reason is every single time I have my patient for the recall evaluation, okay, I see perfect healing. So what do I do wrong? Okay, I was discussing, I will not mention his name, but I was discussing, speaking about lateral canals recently with an Italian guy who says that we don't need to fill. Actually, according to him, it's contraindicated to fill lateral canals. Let me tell you what happened 1 week ago. 1 week ago, Gianno Ricci, the periodontist that I mentioned you before, he sent me a patient to treat an upper left cuspid, okay? And he sent me the preoperative film. Then I took also my preoperative film, and I noticed in the same film of the cuspid, the central incisor was treated years before, having 2 beautiful lateral canals perfectly filled. Then I said, wow, look at this. Believe me, I recognized my patient not by the name, but by the x-ray. I saw the x-ray, I said, wow, look at, who is this? Let me show you. Who is she? Can you see the cover of my textbook?
Yes, very well.
Can you see this image here?
Yes, so that's the one you were talking about.
Exactly. A central incisor with 2 lateral canals. Now, this is my x-ray, and this is exactly the same anatomy described 100 years ago in a textbook written by a Swiss man, the name is Walter Hess, okay, who published an enormous amount of teeth. With a special technique, he was able to demonstrate the real root canal anatomy, okay? And the reason why I put this image in the cover of my textbook, each image is the work, the table has work and my x-ray, work has and my, look at the other one, exactly the same, okay? And this is thanks to Schilder, not lateral condensation. And so when I saw this patient, I went back to the chart and I noticed that this central incisor, this one here, with the two lateral canals, was treated in December 1990, which means 33 years ago. Okay, and the patient is still happy. The lateral canal has filled. No, there's no lesion around, no foreign body reaction, no nothing. Okay, so I'm strongly convinced, but because my patient are convinced me that I'm correct, I'm doing things correctly.
And I can see that makes you very, very happy and proud of your work.
Yes, absolutely.
Yeah, so in your opinion, let's proceed to another question, Arnaldo. Can single pin method be successful?
The single pin method, single cone, you mean? Well, it's very much on fashion now. Let me tell you, this new technique using bioceramic sealer, single cone and bioceramic sealer, and this looks like a panacea. Very easy. You put the bioceramic sealer in the canal, single cone. That's it. Well, I don't have, to be honest with you, I don't have experience on this technique because I don't like it for several reasons. But the main reason is that it's something new. And I am a visiting professor in a few universities in Florence, in Italy, but I'm not a full-time professor in any university, like my friends Elio Berutti, Cantatore, and so on. In other words, I cannot make experiment on patient because they are my private patient. And if something goes wrong, I don't like it. For this simple reason, I'm waiting to read more and more articles, case reports, and study made on using this technique, which can be maybe too easy for people who are lazy and they don't want to use lateral or vertical. Well, it's so easy. One single cone, that's it. No. Listen, this bioceramic sealer, after setting, is hard as rock, okay? Which means that, according to the literature, of course, it's not just my opinion, the retreatment is extremely difficult because you cannot dissolve it, you can remove it, especially if it is around the curvature. How can you remove? If it is straight, with ultrasonic tips, you can vibrate and remove the sealer. But if it is around the curvature, the only solution is what? Something I love it, surgery. Wonderful, thank you, okay? Other problem, the bioceramic sealer in the presence of low pH, it doesn't set. So that if this is used in the presence of some remaining acute inflammation in the periapical tissue, the apical portion, which is the most important, is not setting. So it's going to fail. And then I'm still faithful to what I've been doing for 43 years because I see it is working. I let other people do experiment on patient, not me. And then it looks like the panacea of many, many years ago with the silver point. Silver point are very thin, but very rigid. They could enter in a almost untreated root canal, penetrate in the canal, look very nicely on the X-ray because are radiopaque. Yeah, but they don't seal anything. They don't work. So I've been retreating silver points for many, many years. Now they are not on fashion for many years, so it's very rare, very seldom to have a retreatment of a silver point. But the bioceramic sealer and the sealing of cone, I let other people to do the experiment, not me.
You choose the methods that are already trusted by time and your experience.
Absolutely. There is an old sentence in Italy or everywhere that says, if you change something well known for something that you don't know, you know what you are living, but you don't know what you will find. So yes. Let's wait. Let's be prudent.
That's a great saying. There's an interesting next question, Arnaldo. Could you share from your practice, the most interesting case that you had?
Well, let me tell you that I have more than one interesting. One very interesting that I show almost everywhere I go because it's so unusual. And for several reasons, I have the opportunity to show this case. Is a lateral excisor with an external resorption where the previous dentist was trying to do the obturation, but he left a piece of gutta-percha in the resorption and all the rest of the canal completely empty. And of course, there was a lesion and everything. So the patient was referred to me many years ago, I think about 22 or 23 years ago, because I have a 23 recall now. He referred the patient to me. Under the microscope, I could see through the access cavity the little piece of gutta-percha in the resorbed area, but I couldn't remove it, and also I couldn't find the entrance of the apical port because this resorption was in the mid-root, and I couldn't find the entrance of the apical portion of the root canal. And then I decided, with the thermoplastic gutta-percha, with the gun, okay, to fill the canal, the coronal portion up to the defect, and then raise the flap and complete the case surgically. Once I raised the flap, I saw the entrance of the apical portion. And then I said to my dental assistant, please remove the tray of the surgery, give me everything for non-surgical endo. But I was working with an open flap, looking at the root, the bone, the lesion, and everything. So I started to negotiate with a hand file because there was no rotary at the time for the initial negotiation. So hand file to the working lead, apex locator, and initially the irrigating solution was only saline solution from the syringe of my dental assistant, but then I started using rotary. At the time I was using ProTaper Universal, GT rotary files. As soon as I had enough space inside the canal, I started using sodium hypochlorite, EDTA, like I was working under the rubber dam, but I was working with the open flap. So I dried the canal, I fit the gutta-percha point, I did the shield obturation of the apical portion, and then I filled the defect with white NTA, and then I put the suture. So if you see the X-ray, in the X-ray you see the straight portion, the coronal portion, and then the entrance from the lesion during the surgery from one side with the rotary file. So my post-op, it looks like crazy, like drunk, okay, because it's like this, because I was entering during the surgery from a lateral aspect. And then, well, I show this case, especially when I speak about surgery, because as you can see from my textbook about surgery, I dedicated the first chapter to explain the reason of the title of the textbook. And the title of the textbook is Microsurgical Endodontics, which surgical endodontics is different from endodontic surgery. Endodontic surgery is made by the oral surgeons who don't know anything about endo and this is true because nobody told them during their specialty. So they make surgery for endodontic reasons, but their surgery is to remove the granulation tissue, to remove the cystic wall, maybe put some bone graft, and many, many times they don't even put any retroseal because they didn't understand that their problem is not the cavity in the bone. The problem are bacteria inside the root canal. And you use the surgery to have a surgical approach if the non-surgical approach was impossible, okay? But then you have to seal the fragment from a surgical approach. And still is an endodontic therapy made through a surgical approach. That's why it's called surgical endodontics, because it's an endodontic therapy, okay? So when I speak about surgery during my lecture, my courses, and so on, and I explain the meaning of surgical endo, I show this case, because this is an endodontic treatment, cleaning, shaping, rotary, irrigation, vertical compaction, everything, but made through a surgical flap. That is an endodontic therapy. This is one of the most unusual cases. Another, if you have time, I tell you another one.
Sure.
This is funny also. Many years ago, also about 23 years ago, a young girl, 18 years old, very good looking also, came to my office because a dentist friend of mine put a screw post in the mesial-buccal canal of a lower molar, making a strip perforation. So she had a lesion in the bifurcation, a sinus tract, a fistula, and she was very furious against the dentist who did this problem. And she didn't want to have extraction, implant, nothing. She was only 18. And so I said, well, I will do my best to keep your tooth in your mouth. So I removed I removed the screw post. I removed the gutta-percha. In this case, I was going to seal the perforation with MTA, but because of the low pH in the presence of the sinus and acute inflammation, I used a 1-week medication with calcium hydroxide, not to kill bacteria, but just to raise the level of pH. 1 week later, the fistula was gone. And then in a special way, I did the vertical compaction and I sealed the perforation with MTA. And then I had the 1 year and 2 year recall evaluation. Perfect healing. She loved me, okay, because I saved the tooth. After 3 years, she came back to me with the same problem. And I want you to know that after the second recall with a nice healing, I published this case in an American magazine, okay, Dentistry Today, together with, the article was speaking about MTA and different applications. So I had a direct pop capping, a perforation repair, an open apex, and a surgical case, okay, with a 2 year recall evaluation and a nice healing. Then, after publishing the article, I received some email from good friends of mine saying, oh, congratulations, beautiful cases, blah, blah, blah. But then one dentist from, I think was from Seattle, Washington State. I can remember the name, but I will not mention his name. Okay, he sent me an article, crazy, saying he was shocked by my clinical cases because I removed too much dentin. He said that your cases are the same chance to be successful like a snowball in hell. Wow. In my office, those cases have been extracted and replaced with implants. And it was an email this long. I answered him with an email 2 pages long, with all reference and so on. And then I got no answer from him, of course. But 3 years later, this lady came back to me with a lesion. Then I said, oh my goodness, maybe this guy, this crazy guy from Seattle was right. Then I said, no, impossible. He cannot be right. And I noticed that this lady had the orthodontic appliance And I was pretty sure that because of the orthodontic movement, my MTA was dislodged somehow, leakage, bacteria, and lesion. So I said to the patient, I said, sit down in a dental chair. I will retreat your molar at no charge, even it's not my responsibility, but I want you to heal without spending other money. So I treated at no charge. And then give me the number of the orthodontist. I called him on the phone. I said, please do me a favor. Maybe he has nothing to do, but maybe yes. Don't move that molar. Stabilize the molar. Don't move it. Okay? So I removed my MTA, my gutta-percha, my everything. 1 week calcium hydroxide, the fistula disappeared, and I had the healing one more time. I sealed the MTA with MTA again, the strip perforation, and now I have the 23-year recall evaluation. Now she's a beautiful woman, married, children. She loves me because I saved the tooth. Okay, and I am very happy. This is one day I will write an article in the same magazine, and I send a copy to that crazy guy with a 23-year recall. Not implants, but the original teeth in the mouth.
You shared with us 2 stories, but as I can see, you probably have hundreds more like this.
Yeah, oh, yes.
Well,
I have many.
Let's proceed to our questions. We have a few left, okay?
Okay.
What does it mean to be a successful dentist from your perspective?
Well, to be successful means to be understood and respected by patient, not only by, and of course, by the colleagues. But having a practice limited to endo, 90% or even more, my patients are referred to me by colleagues. I live on referrals, okay? And honestly, I started to receive referrals when I was still going in and up and down to Boston University to take my courses from my teachers at the university, at the specialty. The teacher of prosto, the teacher of pedo, the teacher of restorative. They started to send me patients for endo. And so this is how I decided, wow, I can live on referrals. I will stop doing general dentistry and everything. And this is how I move and where I'm now receiving patient for the endo treatment. And then I send the patient back to them. And what makes me feel happy and successful is that when the patient are informed from the very first day when they come for the first visit, and they sign the information, okay, that part of the therapy is come back to the recall evaluation every 6 months for at least 2 years, because I want to see the healing of the lesion, of no lesion if the lesion was not there before. If I don't recall my patient, how do I know that what I'm doing is correct? Okay, so having the patient happy, the lesion disappearing, and they say, thank you, because you saved my tooth. Or once in a while, when I have the indication, of course, I do the surgery. You should listen what the last patient told me. And I had a group of people taking the course on surgery last weekend. So she came to take the suture out, okay? And she said, doctor, I'm amazed, and I'm telling everybody, I had surgery. I had no pain, no swelling, no nothing. Unbelievable. And I would like to show you the selfie that one patient years ago took of her face after the surgery made by an oral surgeon. Big swelling, the eyes almost completely closed, ecchymosis, terrible story of pain, big swelling, terrible. My patients, sometimes they ask me, doctor, did you really do the surgery to me? Because I don't feel anything. So this is what makes me successful and happy. The patient are, well, one patient a couple of years ago, when I asked, what is the name of the referring doctor? What, you know what he said? She said, the doctor referred to me is Dr. Google. He found my name. Well, of course, and many, they look in Google. They know all of my story, okay? So they come and they say, oh, well, I'm happy I found you. The lady who came from Milano, north of Italy, that she found me on Google, okay? She sent me an email just for her to have information, because her doctor wanted to take to the extraction and implant. And she is around 45, 50 years old, so not so old. And then I said, send me an X-ray. I said, no extraction, no implant, absolutely. According to the doctor, was impossible to remove the obturated material from the canal. It was just some sealer, some little piece of gutta-percha, not even at the apex. So it was extremely easy, okay? So I did the retreatment. She saved money, she saved the tooth. She's happy. And this is what makes me feel very happy and very successful.
Amazing, amazing. Well, now we have two more questions that our listeners probably are most interested in. So do you believe that wisdom teeth are exclusive to wise individuals?
Absolutely no. For the simple reason that, as you probably noticed, my mother forgot to put
Actually, I didn't. That's
my two lateral incisors, they never came out. I had the deciduous teeth, but then the permanent teeth, they never came out. So my two lateral incisors, permanent, are missing since I was a little boy, okay? Not only the two laterals, but also the 4 wisdom teeth. They never came out, never. I don't have, thank God, because many times they had to be extracted. So this is to prove that the wisdom teeth are not exclusive to wise individual. I can survive and be happy without the wisdom tooth.
Lastly, where do teeth go after extraction?
Okay, good question. Let me tell you where I would love them to go. They should go in a little container to be sent to me for my workshops, for to try new instrument and make experiment. I'm always looking for extracted teeth. I'm serious. Not so easy to find. However, usually the extracted teeth are extracted because they are completely destroyed or fractured. And so they go in a special container of infected material. I have a company. We have to have a company who comes once a month to collect from the special container all the infected material that we have during the non-surgical and surgical therapy, where gauze of napkins or with some blood or saliva and everything. So extracted teeth, they go in the same container. And then somewhere, somehow they process all the infected materials. I don't know. But if you know someone who has a big collection of extracted teeth, please save them. And when I will be in Vilnius on May the 4th, I will come, I will put in my suitcase. I hope through custom, through the X-ray, they don't realize I have teeth. And then, because I need this like bread. That's all.
Arnaldo, thank you so much for your time, for your answers, for your energy, your jokes, for sharing your experience with us. It was a pleasure to have such a useful conversation covering various topics. We look forward meeting you on 4th of May in 2024 here in Vilnius. And additionally to that, we would like to wish you and your family a happy holiday season and see you soon. Grazie mille and buona giornata.
Okay, thanks to you, and thanks also to Alina. Give her my best regards. And for sure, we will be in touch. You give me more information about the video, and I will be happy to make the video for you as soon as possible.
Amazing. Thank you. Thanks again.
Okay. Have a nice weekend.
You too. Thank you. Bye-bye.
Okay. Bye-bye. Thank you.